Good evening, everyone. Good evening, consultants, senior colleagues. Want to welcome us all to the day 5 of our revision. Um, we will start today with question 101 to 105. So that there was going to be a bit of overlap because the plan was to assign at least 5 questions to everyone. So there may be overlap. So for those who tend to have those overlaps, you can add on to that question if you have additional information. So, Dr. Akumia, Lawrence,
Yes, yes, I'm here.
yeah, okay. So we start with Dr. Akumia, 101 to 104.
Okay, let's remove your clothes first now. Please,
Are
let's
you
remove
going
your
to mute the person?
Yeah, you can go
Okay,
ahead.
great. So, good evening to everybody. So, my questions are um, 101 to 105, and the preamble to questions 101 to 104 reads: For each clinical scenario, select the most likely ECG from the four traces shown in figure 1.24. So, I'd like for us to look at the various ECG tracers, and then we'll come back to the question. Okay. It's up. It's rather up. So the one labeled A, um, it shows a borderline sinus tachycardia, which also has a right bundle branch block morphology. I can't really, count the small boxes, but I think it's maybe an incomplete right bundle branch block morphology. And then she also has, in terms of, 1 second, please, my phone has moved. Okay, yes. Um, so in terms of axis, the axis also looks like a right axis deviation. And then there's a Magen-White sign, which is S1, Q3, T3. That's also present. I think those are the significant features seen on that ECG. And Magen-White sign is characteristic of pulmonary embolism with significant hemodynamic instability. And it's not common. Very commonly, you find sinus tachycardia, and you can also find T wave inversions in the lateral leads too. So this patient has sinus tachycardia. She has a right axis deviation, right bundle branch block, and also has the S1Q3 T3. So it's likely this patient with this ECG has a pulmonary embolism. So we'll look into that again. And in the second ECG, which is B, you find an ECG that is sinus axis is normal, P wave morphology appears to be normal, PR interval also appears to be normal. QRS duration is normal, but you realize that the amplitude is high, suggestive of a left ventricular hypertrophy. Sorry, please, who is talking? Is it
Lawrence,
possible to
wait,
mute?
I'll mute the person. Just hold on.
Yeah,
You can go ahead.
great. So with the B, there's high amplitude of the QRS complexes, which is suggestive of a left ventricular hypertrophy. And then you realize that there are very deep T wave inversions with associated ST depressions in the V from V3 to V6, and also in the high lateral and the inferior leads. So this patient may have left ventricular hypertrophy with ischemia, but other differentials also include hypertrophic cardiomyopathy. So we would discuss that when we deal with the scenarios that we are given. So we have ECG tracing C. In this one, let me do D and come back to C. So ECG tracing D. So that's also sinus, but you find that there seems to be diffuse um, ST segment elevation with PR, some subtle PR depression. And then if you look in AVR, there's PR elevation with ST segment depression. So this is also seen in cases of pericarditis. You can have something like this. So that goes for D. And for option C, you have a sinus rhythm, and then um, it's very difficult to see the P wave, but I think it is present and its normal morphology. The PR interval, if you look at V1 where you see a clear P wave, is also normal. Axis is also normal. QRS duration is normal. The amplitude is normal. However, you find that for the QT interval, if you use the Bazet formula, it's prolonged. So you have your RR interval being three big boxes with two small boxes, and your QT interval is spanning more than half of the RR interval. So just by looking at it, you realize that the QT is prolonged. But if you go ahead to use the Bazet formula to calculate your QTC, then you realize that it's also prolonged. So, and the T waves also seem to be a bit diminished. They are not as prominent as they are in regular ECGs. So those are the four ECGs we've been presented with. So the scenarios, going back to the scenarios, 101, a 19-year-old male college student with exertional lightheadedness and a harsh systolic murmur that intensifies after standing from a squatting position. So this is describing the murmur of hypertrophic obstructive cardiomyopathy, and the maneuver where when you stand from a squatting position, or you'd be performing a Valsalva maneuver. So whilst you are straining, it decreases the preload to the heart, and that um, exaggerates the murmur of the hypertrophic obstructive cardiomyopathy. And in hypertrophic obstructive cardiomyopathy, you have associated increased left ventricular mass. So there's some form of hypertrophy of the left ventricle, and it often results with associated inverted T waves. So it correlates with the ECGB. So the right match for 101 is B. And then 102 says a 56-year-old woman with sudden onset pleuritic chest discomfort and dyspnea. So we know that pulmonary embolism can be associated with pleuritic chest pain and is often associated with shortness of breath. And it's often of acute onset. So with the ECGs that we described, this was likely going to be A. So 102 would match with A. And 103, a 36-year-old man with sharp inspiratory precordial chest discomforts that radiates to the left shoulder. So usually the pain of acute pericarditis is described as a central chest pain that is worse on lying supine and relieved by leaning forward. But occasionally you can have the pain also radiating to the left shoulder. So in the 36-year-old man here, they didn't give any cardiovascular risk factors, atherosclerotic cardiovascular risk factors to suggest that this could be um, an ST segment, an acute coronary syndrome. With the ECGs we have left, which is C and D, the one that is likely to cause chest pain That's me radiate to the shoulder, is C, which and the ECG we described as something that can be seen in acute pericarditis with the diffuse, sorry, is D, the diffuse ST segment elevation with the PR in depressions in all the other leads, and then PR elevation with ST depression and AVR. So 103 is going to match with D. And 104 says a 71-year-old alcoholic man with epigastric discomfort after 18 hours of intermittent vomiting. So this patient has had um, um, several bouts of vomiting, and with it, maybe associated electrolyte imbalances. So it is possible that the QT prolongation and the diminished T waves we found in ECG tracing C may be due to electrolyte imbalances that this patient may have had from the prolonged vomiting that he has been experiencing. So to go over question 101, suggestive of hokum matches with B. 102, suggestive of pulmonary embolism matches with A. 103, suggestive of pericarditis matches with D. And 104, suggestive of electrolyte imbalances matches with C.
Thank you very much, Florence. Please, do we have any contributions, clarifications, questions? I've gone back to the ECGs if you have questions you want to ask and clarifications. Okay. Thank you very much, Florence. In the absence of any further questions, we move to 105, 106 to 110. Do you have Dr. Catherine?
So 105 is my question, and it's part of the next person's questions. So I wanted to know if the person wants to give an overview before I try to answer my question.
So
105.
I mentioned earlier that there will be overlaps. I think I don't see her on. Is Dr. Catherine Okeke on? Since it's not on, you can just take the 105 and we'll continue and we'll come back and fill in the plot.
Okay.
Yeah.
Okay. So question 105 to 109 are relating to some images from coronary angiography that are attached below. So we are to match the most appropriate descriptive phrase to each of the angiograms shown in the figure 1.25. So question 105 wants us to find an RAO, which is a right anterior oblique projection, which shows the left anterior descending artery, demonstrating myocardial bridging with narrowing in systole and near normal caliber in diastole. So myocardial bridging is something that occurs when the coronary artery traverses muscle. So as the muscle contracts, it impinges on the vessel and causes changes in the it impinges on the vessel. And then as the muscle relaxes, which occurs in diastole, that pressure on the vessel is relieved. So then it regains its normal caliber. It is often clinically insignificant, but in some circumstances, it can contribute significantly to poor blood flow, resulting in ischemia, and therefore having symptoms such as chest pain. So the option A, which has both diastole and systole, the right anterior oblique projection, as rightly described. And then if you look at the left where the arrow points, the thinking maybe the distal left, or I think, I see a first diagonal, second diagonal. So I think it's the distal left anterior descending artery, where during systole, which is the image to the right, there is narrowing of the vessel, evidenced by the filling defects. So you only see a thin line connecting the pars proximal and distal to it, as opposed to the image on the left, where you see that even though there is some narrowing, such that the caliber is less than the areas just proximal and to it, it has regained some of its caliber, so the blood flow through it is better, or the flow of contrast through it is better. So that would match with option 105, which was my question. So for 105, the answer is A.
Thank you very much. To allow people who have been assigned and the questions who I presume will have prepared to answer the questions, I will let us continue. We'll skip the remaining options. And if by the time we are done with those who are on and they are not on yet, we go back and we finish it up. Otherwise, we don't want to encourage if the questions are not answered, we'll be answering for the colleague. We want everybody to be involved. And whilst you are preparing, I believe you may have more information because you have prepared to answer those questions. So on that note, we'll go to if Dr. Innocent Ozo is not on, is Dr. Okechukwu is on. I saw Dr. Okechukwu on. Okechukwu, okay,
Yeah, Eugene.
yeah,
Hello, Dr. Eugene.
yeah, hello.
Yes, sorry, Dr. Mohammed. I just wanted to find out if she could say something why it's right anterior oblique view.
Okay, Florence.
Yes, okay. So where is my slide? So with the projections, the various projections, one second, I just wanted to cross check with my word. So when you have your angiogram, its laterality, whether it's right or left, will be determined by the relation of the catheter to the wire to the spine. So if the the spine is to the left of the catheter, then it is a right view. And if it is to the right of it, then it is a left view. And then we also have the caudal and then the cephalic views, projections. So if you are able to see the diaphragm, then it is a cephalic projection. And if you're unable to see it, then it is um, um, a caudal projection. Now, the right anterior oblique helps you to see the LAD and the circumflex well. So with this, the projection is showing, I'm not able to appreciate the spine much in this, but the view that it shows us the LAD. So that is why it's the right anterior oblique. This is a typical picture you get when you do the right anterior oblique, the 20 degrees one. I don't know. I wanted to talk more about that, but then I feel like it's going to be redundant because the next person is probably going to go all through that because they have more questions about it.
Okay, Florence, if you did prepare to talk about it, since the person is not on, you can follow up with a discussion of the views, any important comments you have on the coronary projections. Then we can let Dr. Kechuku continue. That is if you are comfortable to do that.
I would rather be fair.
Oh, okay, all right. So Dr. Kechuku, kindly take your questions.
Okay. Hi. Good evening, everyone. Uh, this overlap is causing problems. I focus more on the chest X-ray findings because I thought that probably the person before me, had a bulk of the what do you call it? Diastolic function assessment. But if what I'll do is I'll do my X-ray bit. If by the close of if the person doesn't do it, then I'll probably either do it before we finish or I'll do it on Monday. So I don't have a problem. But let me just probably do the X-ray. I think that'll be because it's some way when you do a few, then leave the remaining for others. So I think I can start with 118 to 121 because I mean they come as a group. So okay, sorry, I'm opening 2 minutes. Give me a second. Okay, yeah. So the X-rays is no. I think scroll up a bit. It was a bit confusing. I think it should be the next. Where is it going? Yeah, this one. Yeah. Thank you. So I would go. So the way it is done is I don't know how to allude to the question now. So bottom line is I think there are 4 options. So let me look at so let me just see the order in which it's done. So I think 118 is
So 118
mitral
is about mitral stenosis. The
stenosis.
119 is aortic regurgitation. The
Okay.
120 is atrial septal defects. And the 121 is pericardial effusion. So
Okay.
118 mitral stenosis,
Okay.
119 aortic regurgitation, 120
Okay.
atrial septal defect, then 121 pericardial effusion.
Okay, so so I'll start with the mitral stenosis. So mitral stenosis normally, what you are expected to find, usually, I mean, the etiology, you have a thickening of or a narrowing of the mitral valve orifice. So then that leads to decreased blood flow across from the left atrium to the left ventricle. And there's also a corresponding increase in left atrial pressure. So when you have increase in left atrial pressure, then you have resultant enlargement of the left atrium and then its appendages. So when you have that and the buildup of pressure, you have a back, essentially transmission of pressure from the left atrium into the pulmonary vessels. So when you have elevated pulmonary pressures, you'd also develop a dilated pulmonary artery. So what typically for most cases of mitral stenosis, you have a normal, in most cases, a normal left ventricle. So the focus usually is you find a dilatation of the left atrium and then a transmission of back um, um, pressures to cause elevated pulmonary pressures and dilated pulmonary arteries. So as a result, you tend to have an underfilling of the left ventricle, which will be normal, and then you may have a normal or even slightly reduced left aortic knothole because of decreased blood flow across. So like I said earlier, you don't tend to have what do you call it? A cardiomegaly in them. So other things you could look for. So normal. So you may have less prominent aortic knothole, normal left ventricle. Then you may have what we call a straightening of the
Hello, Okechukwu. Hello. We'll wait briefly if I'm sure he's having network issues.